I'll begin my discussion on pediatric bone lesions with some unknowns. Starting with the first case, this is a chest radiograph on a newborn with multiple fractures. Second case is ankle radiographs as a part of a skeletal survey in a 8-month-old infant found unresponsive. Case 3 is a 7-year-old falling behind growth curves, and you have radiograph of bilateral knee joints with tibia and fibula. Radiograph of the pelvis in a 13-year-old with new right groin pain. And the last unknown is MRI of a 15-year-old with left knee pain and snapping. I'll begin the individual discussion on each cases with developmental dysplasia of the hip. As you can see in this case, this is a classical ultrasound picture of dislocated hip with the femoral head being completely displaced out of the acetabular cup with inadequate coverage by a dysplastic and a shallow acetabulum. Risk factors for developmental dysplasia of the hip are listed as below. It is very much more common in female infants as compared to male infants. It's more common in breech-delivered infants. The female to male ratio is much narrower in this patient group. DDH is also common in cultures where swaddling is a common practice, which puts the hips in adduction and predisposes it to subluxation and subsequent acetabular dysplasia. About 1/3 of the patients have a positive family history. A diagnosis is crucial as early as possible, because the earlier the treatment, the better the outcome. It is helpful to know the ultrasound anatomy for early diagnosis of developmental dysplasia of the hip. Ultrasound is the mainstay in children who have a positive hip examination or who are at who have a risk factor for developing DDH. Ultrasound is performed in coronal and transverse planes in both stress and static maneuvers. And this is a coronal static ultrasound image showing the osseous acetabulum and the cartilaginous acetabulum together with the iliac crest, forming an inverted Y-shaped configuration harboring the non-ossified femoral capital epiphysis. This imaging axis is used to determine the maturity of the acetabulum by determining the alpha angle, which is the angle intersected by the line tangential to the iliac crest and the line tangential to the bony acetabulum. Normal values are greater than 60 degrees. However, up to 3 months of age, angles between 50 to 59 degrees are considered as immature acetabulum and mildly dysplastic in greater than 3 months of age. This line, the line tangential to the iliac crest, is also helpful in determining the coverage of the femoral head by the acetabulum, and it should be normally more than 50%. Transverse imaging, especially 90-degree flexion with stress maneuvers, is helpful to dynamically demonstrate the laxity or subluxation of the hip joint. Plain radiographs are not the mainstay, and if at all, they are used in an established case of developmental dysplasia of hip or in a follow-up or in a delayed presentation, and most of the times diagnosis is not difficult, as it is in this case. You can see in an 8-month-old with a subluxated left hip joint, which is laterally and superiorly displaced with respect to the acetabulum. The acetabular roof is more steeper on the left side as compared to the right side, and there is asymmetric shape and mineralization of the femoral capital epiphysis. Few of the lines that are useful: perpendicular line or Perkins line, which is a line tangential to the outer margin of the acetabulum, normally intersects the proximal femoral metaphysis in the inner or the middle 1/3. You can see it completely misses the metaphysis on the opposite side. The horizontal line transecting the triradiate cartilage levels. Both of these lines form 4 quadrants, and normally the femoral head should be in the inner and the lower quadrant, and as you can see, it's completely dislocated on the left side. The acetabular angle is formed by the line tangential to the bony acetabular roof and the horizontal line, and normal values should be 30 degrees or less. And as you can notice on this image, that the alpha angle that we measure on ultrasound is nothing but a complementary angle in the triangle formed by the horizontal, perpendicular, and the acetabular lines. In case of developmental dysplasia of the hip, the ossification is asymmetric. Sometimes it is delayed. Hence, it is useful to know the normal age, the physiological age for appearance of ossification. It's 2 to 6 months in girls and slightly later, that is 3 to 7 months in boys. However, with a developmental dysplasia of the hip, it's almost always asymmetric, even if it is bilateral. When you have bilaterally symmetric delayed ossification or non-ossification, you should think about endocrinal or metabolic generalized disorders. This is a 17-month boy with hypothyroidism and non-ossification of the femoral capital epiphysis on either side. Moving forward to a set of cases with common clinical presentation in a child with limp. The first case is that of leg calf Perthes disease. This is an Aunt Minnie showing fragmentation, sclerosis, and flattening of the left femoral head and irregularity of the physis in a patient presenting with left groin pain or limp. Leg calf Perthes is basically an aseptic idiopathic avascular necrosis of the immature femoral head. It's more common in the age group of 5 to 8 years, more common in boys, and more common in Caucasian race as compared to Afro-American. A point to be remembered is it is usually unilateral, and whenever it is bilateral, it is almost always asymmetric. So whenever you have a case of bilaterally symmetric avascular necrosis, you should think of systemic causes like steroid use and sickle cell disease. Other causes of unilateral avascular necrosis would be in differential as well. That would include infection, trauma, and infiltrative disorders like Gaucher disease. Mere dysplasia is one of the differential diagnoses for the radiological appearance of an aseptic necrosis. It is basically an osteochondrosis, an irregularity of ossification. It is usually encountered in children less than 5 years of age, unlike Perthes disease, which is in children greater than 5 years of age. And it is almost always asymptomatic and incidentally detected, unlike Perthes disease, which presents with groin pain or limp. Next is a case which is a common condition for a child presenting with limp is septic hip. You can see a sagittal sonogram showing distension of the joint capsule of the right hip joint and normal left hip joint space. Usually radiographs precede ultrasound for the diagnosis of hip joint effusion. However, they are not very sensitive for diagnosing effusion per se, but they can be helpful in diagnosing or detecting additional associated findings. This is a patient with osteomyelitis of the left femoral neck. There are subtle signs to suggest joint effusion indicated by widening of the teardrop distance as compared to the contralateral and subtle displacement of the obturator fat pad as compared to the normal on the contralateral side. Certain other fat pads like the psoas and the gluteus medius fat pads are useful signs for commenting on or detecting joint effusion. So septic arthritis is the most common cause of arthritis in children. Usual organisms are staph or streptococcal group of bacteria. In neonates, the coliform bacteria form the major etiological organism. As I said, radiographs are not very sensitive. However, combined with ultrasound, they form the first modality for investigation. MR is the most sensitive and specific modality for diagnosing and quantifying the arthritis. An additional example in an older child, T1 and post-contrast fat-saturated T1 images showing a well-circumscribed low-signal lesion in the femoral neck, which on post-contrast imaging shows enhancement, which is preferentially more in the margins of the lesion rather than in the central part of the lesion, together with diffuse exuberant enhancement of the synovium. This was a case of subacute osteomyelitis or Brody's abscess complicated by septic arthritis. So joint effusion is not always infectious in children, and there are several other etiologies of joint effusion. Important among that age group, which is an important differential diagnosis, is toxic synovitis, which has similar presentation in the similar age group, and radiological differentiation can be very difficult. Toxic synovitis is basically an inflammatory response to an antecedent infection, usually viral. It affects boys more than girls, and it's in the age group of 3 to 10 years. And as I said, the clinical presentation can be of a limp. However, it is usually gradual as compared to septic arthritis, which is associated with a more acute course. Arthrocentesis may be essential to diagnose, to differentiate it from septic arthritis. However, the clinical recovery is complete, and it's within 1 or 2 weeks as compared to septic arthritis, where it is progressive. Moving forward to our fourth unknown case, this was a case of 13-year-old with new right groin pain. This was a case of slipped capital femoral epiphysis. As you can see in the right hip, there is medial displacement of the femoral epiphysis and irregularity and widening of the femoral growth plate. There is a slight offset of the femoral neck with the femoral epiphysis as compared to the normal on the left side. MRI on a different patient shows similar findings of diffuse bright signal in the medial aspect of the proximal femoral physis and the metaphysis, and the T1 image show medial and inferior displacement of the femoral epiphysis and offset at the level of the neck and the epiphysis. So slipped capital femoral epiphysis is basically a Salter type 1 fracture, which eventually leads to displacement of the femoral epiphysis either posteriorly or medially. It usually occurs in the adolescent age group, unlike Perthes disease, which is in 5 to 10 years of age group. And this is associated with a hormonal spurt and changes related to closure of the physis depending on the hormonal spurt. It's more common in boys, it's more common in African American as compared to Caucasians. The children are usually overweight for their age or tall for their age. Just like Perthes disease, slipped capital femoral epiphysis without any underlying primary cause is unilateral. If at all it is bilateral, it is almost always asymmetric. So whenever you encounter a bilaterally symmetric slipped capital femoral epiphysis, you should think of systemic endocrinal and metabolic conditions like hypothyroidism, hypopituitarism, or renal osteodystrophy. The slip can be classified as acute versus chronic depending on the presentation. Chronic is most common, and stable versus unstable depending on the ability of the child to bear weight without crutches. Next is another common case encountered in our practice in child presenting with lower extremity pain is of juvenile osteochondritis dissecans. This is a classical case of bilateral juvenile osteochondritis dissecans with osseous defect in the lateral aspect of medial femoral condyle bilaterally, more so on the right side with some sclerosis of the subchondral bone. MRI of a different patient showing an osseous defect, again in the same location, the lateral aspect of the distal medial femoral condyle on the T1 weighted images, and on the T2 weighted images, this is the proton density image showing marrow edema in the subjacent bone at the site of the osseous defect. The cartilage overlying the defect is intact. Osteochondritis dissecans in children is secondary to repetitive compressive microtrauma, usually in adolescent age group. However, it can occur in younger age group as well. The common sites are distal femur, the classic location being the lateral aspect of the medial condyle. Talar dome is another common location, and the third most common location is the capitellum of humerus. MR imaging is helpful, and it is the mainstay of our management as it helps in assessing the size of the lesion, the stability of the lesion, and the intactness of the cartilage overlying the osseous defect. Another common cause of anterior knee pain in adolescent age group is Osgood-Schlatter disease. It's classically demonstrated in this case on a lateral radiograph of the knee joint, showing soft tissue swelling overlying the tibial tuberosity, which is fragmented and irregular as compared to the normal on the left side. Also note some inflammatory change in the Hoffa's fat pad as compared to normal Hoffa's fat pad on the left side. This is a classical example of Osgood-Schlatter disease, which is one of the osteochondrosis involving the tibial tuberosity apophysis. Now, the osteochondrosis can be a normal variant of development. They are considered as pathological only if they are symptomatic. As in the current case, this patient had soft tissue swelling and inflammatory changes in the Hoffa's fat pad. In absence of any clinical symptoms, this would be counted as a normal variant in spite of being fragmented and sclerotic. So diagnosis is usually clinical, and imaging is not used to confirm the diagnosis. It is used to rule out other pathologies and other causes of anterior knee pain. It most frequently involves 10 to 15 years of age group. This was our unknown case 5 of a child presenting with snapping and chronic knee pain. This is a classic example of a discoid meniscus. The lateral meniscus, instead of being tapering in the medial aspect, continues with the same thickness and reaches all the way till the intercondylar notch. And on the sagittal T1 weighted image, instead of classical bow tie appearance, it shows a horizontal thick pancake appearance. You can also see there is a diffuse high signal within the substance of the meniscus, suggesting mucinous degeneration. So discoid meniscus is a congenital abnormality. It can be asymptomatic, but when it is symptomatic, it presents as a chronic knee pain, clicking and snapping, and complication-wise, it is prone to mucinous degeneration and complex tears. The morphology is called pancake rather than crescent shape. However, it's not just the morphology that counts for the diagnosis of discoid meniscus. Any meniscus reaching up to the intercondylar notch with the length in the coronal diameter greater than 17 or 18 millimeter would classify as a discoid meniscus. Moving on to a representative case for alignment abnormalities in children. This is a case of Blount's disease. Radiograph of the knee joints showing varus alignment, and you can see that instead of horizontal orientation of the proximal tibial growth plate, the medial aspect has more inferior inclination, as quantified by what is called the metadiaphyseal angle, formed by the line perpendicular to the tibia and a line perpendicular to it and transecting and tangential to the alignment of the growth plate. So this is a case of bilateral Blount's disease presenting with tibia, presenting with genu vara. Blount's disease has a bimodal peak of distribution. It can be encountered in the infantile age group, and a second spurt is encountered in the adolescent age group. Both have different presentations and prognosis. The infantile form usually is bilateral, and so sometimes it is difficult to differentiate from physiological bowing, especially from 2 to 3 years of age. However, the prognosis is better and it responds to conservative management. Whereas the adolescent age group usually is unilateral, does not present as an alignment abnormality, it presents as knee pain, and it requires surgical correction because remodeling is almost impossible at the age of 8 to 14 years. Blount's disease is more common in African American population as compared to Caucasians. A quick look at the differential diagnosis of varus alignment of the knee joint or the tibia. The varus alignment is physiological till 2 years of age. After that, it starts to straighten up and it goes towards more of a valgus alignment. But up to 2 years of age, it can be physiological. Apart from Blount's disease, other causes of bone softening like rickets, renal osteodystrophy, and osteogenesis imperfecta can cause either genu vara or tibia vara. Fibrous dysplasia is also a well-known case of asymmetric tibia vara. Another common condition in pediatric foot is tarsal coalition. This is an example of calcaneonavicular coalition. As you can see on the oblique radiograph of the foot, there is narrowing of the calcaneonavicular joint space with sclerosis of adjacent bone margins of calcaneum and navicular tarsal bones. The stir sagittal image of the foot shows increased signal at the calcaneonavicular joint and in the marrow adjacent to the joint. This is an example of a non-osseous tarsal coalition, most likely cartilaginous. Tarsal coalition is basically an anomaly of segmentation of the tarsal bones. Very rarely it can also involve the carpal bones. In the pediatric population, it is the most common cause of painful flat foot. In adolescent age group, it may present as frequent ankle sprain and may be diagnosed only after subsequent visits. If you see the distribution, about 90% are talocalcaneal and calcaneonavicular, with 10% forming rest of the forms of tarsal coalition. Up to 50% can be bilateral. The coalition can be osseous, it can be fibrous or cartilaginous. This is our case from unknowns, 8-month-old found unresponsive. The frontal radiograph of bilateral ankle show what is called the classical metaphyseal lesion or corner fractures in both the tibia and fibula bilaterally with periosteal reaction suggesting subacute nature. This is a very characteristic lesion associated with inflicted form of mechanism of injury rather than accidental form of mechanism of injury. Another example, oblique chest radiograph showing multiple fractures involving both the anterior and notably the posterior aspects of several ribs at various stages of healing. Again, this pattern of fracture has a high specificity for inflicted mechanism of injury. Listing some common fractures in non-accidental trauma include multiple fractures of varying age at different locations or unsuspected fractures, classic metaphyseal lesions, diaphyseal fractures, especially in a non-ambulatory child, skull fractures. The less common fractures involve spine, bones of the hands and feet, and clavicle. Less common or very uncommon fractures involve scapula, pelvis, sternum, and the facial bones. Amongst these, the fractures with higher specificity are classical metaphyseal lesions, rib fractures, and fractures involving the spine, scapula, and the sternum. Fractures of varying age at different locations have moderate specificity. Sometimes, this is an example of a non-accidental trauma detected in an unsuspecting child. A child presents with investigation for a different reason, gets a chest radiograph, and there's an incidental note of exuberant callus in the proximal right humerus, and dedicated evaluation of the humerus shows a displaced fracture in the stage of healing with callus and periosteal new bone formation. This was a case of non-accidental trauma. So not only the radiological findings, but the clinical context and the discordant nature of the history are essential to put the diagnosis of non-accidental trauma. I'm showing some examples of corner shots of skeletal lesions detected on chest radiographs. This is our first unknown, a newborn presenting with multiple fractures. And you can see that the fracture involves the shaft of bilateral humeri, several ribs as well, and they are already in various stages of healing, which indicate intrauterine timing of the fractures. This was a case of osteogenesis imperfecta. which predisposes to multiple fractures, axial and appendicular skeleton. Another example, this is a 4-week-old infant with interrupted aortic arch who was on a prostaglandin infusion for patency of ductus arteriosus. And you can see exuberant but lamellar periosteal reaction in bilateral humeri and also involving the clavicle, if you can appreciate that. This is a case of prostaglandin periostitis without any acute fracture. Another example of fracture in a first newborn, day 1 of life, difficult labor shoulder dystocia. And this is a classical example of birth trauma-related skeletal injury. Note that there is no periosteal reaction to suggest an intrauterine date of injury. A quick look at the differential diagnosis for periostitis. Usually focal periostitis, you should think about aggressive neoplastic etiologies like Ewing sarcoma, leukemia, or neuroblastoma, and infiltrative disorders like histiocytosis. With diffuse periostitis, you should think about physiological periostitis, which can be normal up to 5 months of age. Scurvy and hypervitaminosis A can cause diffuse periostitis. Other causes of focal periostitis which are more common, include post-traumatic infectious and stress fracture-related periostitis. Others are rare causes of diffuse periostitis, including Keffi's disease or infantile cortical hyperostosis, and in the current example that I showed, prostaglandin-induced periostitis. Representative case for skeletal dysplasia. This is a patient with osteogenesis imperfecta showing abnormal mineralization of the skull vault with multiple Vermean bones, as you will see in the next image, and deformed bones with multiple fractures at varying stages of healing. Osteogenesis imperfecta is a type 1 collagen abnormality. Radiologically, it is not required to differentiate type 1 from type 1 and type 2 from other types of osteogenesis imperfecta. It is good enough to classify it as mild, moderate, or severe degree of involvement, and the classification can be made by lab and biochemical abnormalities. The classical presentation is that of multiple pathological fractures at birth. These patients also have an abnormal number of Vermean bones. This is an example of multiple abnormal Vermean bones, predominantly in the lambdoid and the posterior parietal sutures. These are intrasutural bones, and they can be seen in a variety of conditions, most common among them being osteogenesis imperfecta. However, they can be also seen in conditions like hypothyroidism, rickets, and other uncommon conditions like cleidocranial dysostosis and pycnodysostosis. This was our unknown, case 3, 7-year-old falling behind growth curve. This was a case of hypophosphatemic rickets manifesting as bilateral medullary nephrocalcinosis and classical changes of rickets in the form of widening of the growth plate, cupping of the metaphysis, and fraying of the metaphysis. There is also mild bowing of the proximal left tibial shaft. There is a very long differential of etiologies of rickets. I would limit the discussion to this representative case. Moving on to examples of common bone lesions, common bone neoplasms in children, starting with the benign tumors. This is an example of enchondromatosis, radiograph of the hand showing multiple expansallytic lesions of various degrees involving multiple bones, and the radiograph of hemipelvis and left femur showing elongated expansal lucent defects in the metadiaphysis of the femur and proximal tibia, and also involving the iliac crest. These are cases of enchondromatosis, which are typically associated with 2 syndromes, Maffucci syndrome and Ollier syndrome. Maffucci syndrome is associated, in addition to enchondromatosis, with multiple hemangiomas, and it has poor prognosis as compared to Ollier's because of potential for malignant transformation. Ollier syndrome can be isolated or it can be generalized. Very rarely, it can be also segmental, involving just one part of the extremity. Next is an example of a proven case of aneurysmal bone cyst, classical minimally expansallytic lesion with very thin septations, if you can appreciate that, with pre and post contrast T1 MRI showing the intramedullary location of the tumor and multiple enhancing septation. This is not very specific radiologically, and the differential diagnosis for expansallytic lesion in children should always include giant cell tumor, unicameral bone cyst if there are no septations. Fibrous dysplasia should be another differential. Osteoblastoma is an uncommon differential diagnosis. Very rarely, osteosarcoma can present as telangiectatic expansallytic lesion. Histiocytosis is an important condition in children, and it can have varied presentation, and it is considered to mimic almost anything and everything in pediatric skeletal cases. This is a classical presentation. This is an Aunt Minnie for histiocytosis with a well-defined loosened defect in the skull vault. There are actually 2 of them in this patient. And CT scan at that level shows the classical, what is called a beveled edge, which indicates a greater degree of erosion of the outer skull table as compared to the inner skull table. Differential diagnosis for a focal calvareal lesion in a child would include, apart from histiocytosis, osteomyelitis, and other uncommon etiologies like neuroblastoma metastasis, dermoid or epidermoid, hemangioma, or very rarely in the hyparietal region, they can be normal variant prominent parietal foramina. This is a case of lymphoma presenting with vertebra plana, plain film, CT scan, and a T1 post-contrast fat saturated image. You can see on the T1 on the MRI, you can see relative preservation of the height and signal in the intervertebral discs and pre and extradural soft tissue with diffuse enhancement of the collapsed vertebral body. You can see fragmentation of the vertebral body on the CT scan and the plain films as well, with minimal kyphotic alignment at this level. This is not specific for lymphoma, although this was a proven case. Other differential diagnosis for vertebra plana in a child would include post-traumatic and infectious spondylitis. Histiocytosis classically presents as vertebra plana, but lymphoma should be included in the differential always. Quick look at 2 common neoplasms in children. Osteogenic sarcoma. This is the most common malignant tumor in children, usually presents in second decade of life. This is a very classic example with mixed lytic sclerotic areas in the proximal humerus, exuberant osteoid and periosteal elevation, and MRI in the same patient. This is a T1 weighted image. This is a post-contrast T1 showing the intramedullary and the extraosseous component of the tumor. And another example of the second most common malignant neoplasm in children of Ewing sarcoma involving the diaphysis of ulna. We can see minimal medullary expansion with sclerotic abnormality in the medullary space and lamellar periosteal reaction, which is confirmed on MRI, showing heterogeneous medullary enhancement and periosseous enhancement. This is a biopsy-proven case of Ewing sarcoma. However, whenever you encounter an aggressive bone lesions, always think about other differential diagnoses like osteomyelitis, which can mimic Ewing sarcoma, histiocytosis, which can mimic both Ewing sarcoma and osteosarcomas, and lymphoma as well.